So this is a discussion on motion preserving surgical alternatives of SNAC and SLAC wrist. Next slide. These are my disclosures. Next slide. The SLAC wrist is very common. As a matter of fact, when we looked at this prehistoric human, 7,000 years old, was frozen in Europe. It was found that he had SLAC wrists on both sides. So this is probably the longest follow-up I've had. Next slide. There are 4 categories for a SLAC wrist. One is just at the radioscaphoid articulation distally. One is the entire radioscaphoid joint. 3, and is the most common that we're talking about, would be involvement of the capitolunate joint, and then 4, which involves the entire radioscaphoid joint, radiolunate joint, and capitolunate joint. And we now have an ability to treat that as well. So initially, the SLAC wrist was being treated for SLAC 3, but now we have the ability to do SLAC 4, and we'll discuss that a little bit later. Next slide. The decision making is magnitude of the complaints, age of the patient, level of physical activity, and radiographic stage, as we discussed earlier. There are patients that have a symptom-free SLAC wrist, which need no treatment whatsoever, but most of them do have symptoms. So back to the next slide. There are other alternatives for treatment of SLAC wrist. There's denervation, which is a treatment that's, in my experience, does better when there's not much arthritic change present. This study only demonstrated 59% improvement. So it's not for everybody, but it's something that we can consider. Next slide. There's the 4-quadrant fusion. There's some issues with that. There's loss of motion, at least 50 to 70%. And there's the complication rate is somewhat higher. We've had non-union rates of up to 25%. Next slide. Capsular interposition, as described by Dick Eaton back in 1996. It's an alternative, although in this study, 3 of the 8 had progressive arthritis despite the capsular interposition. Next slide. Joe Imbriglia has described the use of an Oates procedure, which is an osteoarticular graft, which can be placed in the lunate. If you're doing a proximal carpectomy, you can take it from the lunate into the capitate, and it's an alternative which is reasonable. Next slide. And then there's the capitolunate fusion. The only issue with that is that 5 of the 16 patients in this study had the hardware had to be removed. Next slide. There's a distal radius hemiarthroplasty, which we tried many years ago. The problem that we had is that as you can see in this CAT scan, is that the implant itself was impinging on some of the surrounding bones, and patients were having symptoms from that, and so we've kind of not gone that way anymore. Next slide. This is Scott Wolf's distal radius implant, which it showed some promising results. However, it's not approved in the United States. It's only in Europe, and so that's an issue with trying to use it. Next slide. We tried the carpal side hemiarthroplasty, and the problem with that is that there was marked ulnar subluxation, and so we stopped using that as an alternative. This was just a half of a total wrist implant. Next slide. So here's another alternative. It's a hemicapitate resurfacing implant. It essentially converts a capitate into a lunate. And we have the ability to shape the implant to measure the congruency of the lunate to the lunate fossa, and the carpal height is improved, which is a benefit over a regular proximal carpectomy. Next slide. It's conically shaped titanium alloy fixation screw, cobalt chrome modular resurfacing cap. It is a taper, a Morse taper, and it has porous ingrowth. Next slide. The animal studies have shown that it's safe, it's biocompatible, and there's excellent bone remodeling abutting the anchoring screw. Next slide. Normally, your carpal height ratio is 0.52. We know that with proximal carpectomy, it's 0.37, and the benefit of this capitate cap is that it improves the carpal height ratio and thereby improves some of the issues with regards to flexor tendons and extensor tendons in terms of length. Next slide. This is a study that looked at PRC congruency. I'm sure many of you have looked at the shape of the capitate when you're doing a proximal carpectomy and wondering whether that shape would affect the outcome in terms of DASH scores. And this study showed that poor congruency was associated with poor results for DASH score at 5 years. So this implant obviates that problem by implanting an implant that is congruent with the lunate fossa. Next slide. Indications: SLAC stage 3 and 4, snack risk, Keenbox, fusion conversions. We've done several. Inflammatory arthritis, question mark. We're not sure whether this is an effective treatment for rheumatoid or psoriatic arthritis. But we think now that we have the ability to resurface the radius that it can be, and also for failed proximal carpectomies. Next slide. Contraindications: inadequate bone quality, obviously infection, and if there's no wrist extensors, this cannot be performed. Next slide. Retrospective review from September 2015 to now. It was one surgeon, it was me. Quick DASH scores, grip strength, wrist motion, prior surgeries, and complications were all looked at. Next slide. Rehabilitation for these patients: they were mobilized for 2 weeks. Then they began range of motion with a removable splint. This is followed by strengthening, weight bearing at 2 months, and impact activities at 3 months. Next slide. Now, this is a quick video showing this is a very easy procedure to perform. You perform a proximal carpectomy. There's a device that you place on the capitate with a pin. Then over this pin is a screw. It's first drilled, and there's a line that goes to show you where in terms of the depth. Then the screw is placed very easily over the pin into the capitate. There's the line that tells you how their depth required. And then the device is removed. The screw is maintained in the capitate. Then another device is placed over the pin, which allows you to get your proper length on the capitate. There will be some debris that will be removed after this is placed. Then you have the trial, and then the actual implant is placed. And then, again, this is a taper, a Morse taper, and it's very solid. Then you can assess your range of motion, both radiographically and fluoro. It's a very simple procedure to perform. And this is what it looks like on fluoroscopy. It's very stable in all planes. Next slide. I performed this procedure on 125 patients, median age of 61, wide variety of mostly slack and snack wrists, 5 fusion conversions. 52 of the patients had no prior surgery. All the other ones had a prior surgery. And 78 patients to date have greater than 2-year follow-up. Next slide. The average follow-up was 3.8 years to date. Grip strength improved from 56 to 80 pounds. Motion improved. Quick dash was improved. And carpal height was somewhere between a regular proximal carpectomy and your normal carpal height. There were 10 complications out of the 125, which I'll review, and 2 were revised to 2 total wrist fusions. Next slide. Here's an example of a 67-year-old right-hand dominant male. Chief complaint of left wrist pain, thumb pain. He injured his left wrist while playing football in college many years ago. Progressive symptoms. He's tried Voltaren gel and wraps, and this is, you look at his range of motion. Markedly positive Watson test on the left. Next slide. And this is what we did. We converted this slack wrist to a capitate cap. And you can see that his grip strength improved to 80%, a 3.5-year follow-up with excellent motion. Patient is very grateful. Next slide. This is a 3-month follow-up. This is a patient who's lifting weights. It had absolutely no symptoms. There's no operation for a slack wrist that I know of that will produce this. Next slide. So the complications rates were the following. 6 patients had erosion into the radius, and we're not certain why this occurred in these 6 patients because it didn't seem to be related to time, whether this occurred quickly or later. And we're still evaluating this. 3 patients had subluxation, as you can see on the right. 1 had heterotopic ossifications. There were no infections, and there was no loosening of the implant. Next slide. So here's a complication. There's a 62-year-old right-hand dominant caseworker, had 1 year of wrist pain. Next slide. And we placed this capitate implant. Now you can see that there's a cyst in the lunate fossa, and I should have recognized that this was going to be a problem. Next slide. So what occurred was he subluxed. And so what we did, next slide, was we placed an implant on the radius side. This happens to be a toe implant. And the patient did very well with that implant. Next slide. But we had some of these patients, even with a toe implant on the other side, that subluxed. And this was 3 of the patients out of the 125. And I did a procedure to treat this. What I did was I took the ECRL and I took it through the ulnar side of the capitate, back through the radial side into the radius. Next slide. And I used a internal brace with this, and the patient did very well. You can see the drill holes I put in the radius. Next slide. And the patient was very happy. Now, for the patients that are having this radius erosion, is there something we can do to prevent that or treat it? Now, initially, I was doing a capsular deposition as described by Dick Eaton to try to prevent that erosion, and that's one alternative. Next slide. Other alternatives include a meniscus allograft, dermal allograft, an Oates procedure. Next slide. And this dermal, well, here's the Oates procedure as described by Joe Imbruglia. I've used that. I've used on the other side, on the left side of the screen, you can see a dermal implant. Next slide. I've used the dermal allograft, which has been very successful. Next slide. But now we have an alternative to cover the radial side. This is an implant from the same company, and it's very easy to put in. And this would be, and this is what I've been doing now for almost all of the capitate caps, which is a distal radius implant. It's simple to put in. It's in various sizes, depending on the size of the radius. And I think this is a solution to my issues with regards to erosion in this regard. Next slide. We have had patients where we took down total wrist fusion, as you can see on the fluoroscopy there. Next slide. We took the plate out. Interestingly enough, the extensor tendons were still intact and still worked. This patient had a fusion for 30 years, and I converted that to a PRC and an Arthrosurface. The patient is very grateful to have motion. Next slide. This is the surgical slides. In addition, we put a dermal allograft on the radial side. Next slide. And this is what it looks like. And patient very grateful. Decent motion, about 30 degrees in each direction. Next slide. Here's a patient who's a 50-year-old brain dominant chef with bilateral wrist pain. You can see on the left side here that he had a failed total wrist fusion. You can see the broken screws distally. Next slide. And this is a procedure that was performed on the contralateral side. There was an attempt at a radioscapulated fusion, which failed. Next slide. You can see that in addition to the radial ulnar joint procedures that the capitate cap was placed, the patient was very grateful. Next slide. He went back to his employment as a chef. Now, there are other studies that have looked at resurfacing the capitate. Now, this is a study out of Australia using a pyrocarbon implant. Next slide. They looked at 29 patients with 35-month follow-up. You can see the diagnoses that was performed, and very successful results you see in the next slide. Here's a case study of a 30-year-old male, snack wrist, had previous excision of the proximal portion of the scaphoid, which is a somewhat unusual procedure. Next slide. And this is an X-ray of excision of the proximal portion of the scaphoid. Next slide. And you can see that this is the implant that they used, similar to the capitate cap. Next slide. Again, you can see the implant in place. Next slide. And a 48-month follow-up had excellent results. Next slide. Was jet skiing without pain, and a 113-month follow-up. These are the range of motion, excellent grip strength, minimal pain. And so it's not simply our results, or my results from 125 patients, but it's been looked at in other studies with a successful result. Next slide. Now, also, this study, which looked at a pyrocarbon capitate resurfacing, also had excellent results. So there's been 3 different groups of patients that have had a replacement of the resurfacing of the capitate with excellent results. Next slide. And if you look at the radius of curvature in both the coronal and sagittal plane, and you look at the lunate fossa, you look at the capitate, and you look at the PRC plus, which is the capitate cap, you can see that the results are much closer to the normal anatomy when compared to the simple capitate itself. Next slide. Carpal height is improved, which should improve grip strength and motion and more normal anatomy. Next slide. So this procedure, which is a capitate cap, I call it the PRC plus, the congruency is improved because there's several different sizes that can match the lunate fossa. It's reproducible. It can be done with any arthritic stage now, even in stage 4 slack wrist, where the radiolunate involvement is present, because we can now resurface the radius. And the survivorship is excellent when looking at long-term studies. Next slide. Thank you very much.
Thank you, Dr. Culp. I do have a couple questions for you.
Okay.
Okay, the first question, when you're looking at patient selection, who's ideal and how perfect does the proximal side need to be?
The ideal patient would be, if you were just going to do the capitate cap, would be a slack 3 patient, where the involvement of the capital lunate joint is present. And I've had some patients that didn't want to have the radius resurfaced. They just want to have the capitate cap, and I think that's very reasonable. The patients that are slack 4, and I think that the radius implant is the newer one, is an excellent solution to that. And I think it's also very applicable to patients that are slack 3 as well, because it will prevent the issues of erosion in those few patients that have this complication, that you can treat that immediately by putting in a distal radius implant.
Great, thank you. In your opinion, how revisable is this compared to the current gold standard of wrist fusion and arthroplasty?
Yeah, there's no question that that the patients are more grateful to have motion, when compared to a total wrist fusion. I think one of the benefits of this alternative compared to the other procedures, including joint replacements, that it's very simple to put in. This can be done by, it doesn't have to be done by a hand surgeon. It can be done by an orthopedic surgeon, plastic surgeons that do wrist surgery. You'll notice that if you perform this procedure, that it's very easy to put in. I think that's a real benefit compared to some of the other wrist replacements that are out there, which are very complicated.
Great, thank you. What should a patient expect in terms of function, golf, manual labor, et cetera? How much are they able to lift with their wrist hemi implant in?
One of the beauties of this procedure is that they have no restrictions. Any other wrist replacement that's out there will have a 10-pound weight restriction for life. This procedure, that you can go back to any activity that you want, and we've not had any loosening issues with that capitate cap. So I have patients that have played golf. I've had patients that participate in motocross, and there's no other implant out there that allows you to go back to all activities. They could expect to get about 80% of motion and about 80% of your grip strength back with this procedure.
Great, thank you. Learning curve for surgeons. What are the most difficult, important elements of the surgical technique, or what are your, tips and pearls that you would tell to another surgeon while doing this for the first time?
I think that some of the pearls are as follows. The actual placement and the drilling of the procedure is simple, but when you're placing the implant onto that taper post, you have to make sure that is put in solid. You should not be able to pull it out at all when you're done. You should be able to almost lift the wrist out of the operating surface, because it's so solidly placed on that taper Morse taper.
Thank you. Those were all the questions I had. Sandy, do you have any questions?
No, I don't. Thank you. That was really insightful. So yeah, I don't have anything else at the moment.
Great, thank you. Dr. Culp, thank you so much for doing this. And we are going to play this for our training on the 25th, and they may email some questions over to me, and I will send those to you if you don't mind answering those as well.
Excellent. I will be available.
All right. Thank you so much. Have a great day.
You do the
Thank
same.
you. Thanks. Bye-bye.